Benign prostatic hyperplasia causes a slow and progressive compression of the urethral canal, which is the canal that connects the bladder to the tip of the penis. This causes certain symptoms. The vast majority of surgeries are carried out on patients who have symptoms such as difficulty urinating, a weak stream, going to the toilet too often, urinating, not seeming to empty their bladder completely, waking up at night. One major advantage of MiLEP, a minimally invasive enucleation, includes the ability to use slimmed-down surgical devices. This makes it less intrusive during operation. The reduction in trauma to the urethra means that we have a much calmer post-operative period without symptoms of burning in the canal. The conventional HoLEP surgery and prostate RU, which were traditionally carried out for a long time, utilize the 26-Frent device for their procedures. It's a device that is associated with some degree of trauma to the urethral canal. So, both when the device is inserted and during all the manipulation, it stretches and rubs against the urethra, which causes some discomfort in the post-operative period due to this trauma. In more narrow urethras, the caliber device's trauma can trigger fibrosis, which involves scar tissue formation in the urethra. When it comes to urinating, the patient can't have the same stream 40 days after surgery because the canal closes. How was device miniaturization achieved? Used laser fiber in endoscopes, which is a 0.5 mm fiber that we pass through the endoscope and which will coagulate the blood vessels while we perform the enucleation. Utilizing an incredibly slim device presently enables us to operate on a prostate of any size. Utilizing this slimmer tool that glides effortlessly along the entire urethra up to the section where we will manage the prostate. This reduction in trauma means that we can practically eliminate the risk of urethral stenosis. Today, we are scheduled to operate on a patient who has experienced urinary retention, requiring a catheter. We will be conducting this surgery together, using a particularly slender device. Here, at the Augmented Prostate Institute, I, Felipe Figueiredo, do all the surgery, 100% of the surgery. I perform all the surgeries personally, from the moment of device insertion to the probe placement completion. This also ensures patient safety. I was in the operating room. The nurse was already preparing everything. The anesthesiologist was by my side, and suddenly someone put his hand on my chest. And I look, and there's that big smile, and I say, "I'm here. Dr. Felipe, correct?" This information has already helped to alleviate my concerns. The golden rule of medicine is to do for patient only what you would do for yourself. Every tiny detail of the surgery is of concern to me, and I ensure its success. Today, I'm operating with a team of 3 consistent members who standardize every step of the procedure, from setting up the operating fields to arranging the instruments on the table, thus reducing any chance of variability. The procedure remains consistent with the same attention to detail, ensuring our impressive outcomes, including tube removal within less than 24 hours and patient hospital discharge on the same day. MiLEP's instruments are distinct for their smaller caliber, notably the optics, a very thin tube, which measures 2. There are a number of glass lenses inside, measuring 9 mm, which enlarge the picture. Thus, due to the numerous lenses in close proximity, the image magnifies 20 times. And then on top we use the resectoscope, which has the working element, which is where the laser fiber is attached. And it features 2 small knobs. Through the middle of the device runs the serum inlet, while at the end, extremely tiny holes allow for the disposal of serum. All the energy from the laser passes through this optical fiber. The fiber measures 550 micrometers, or 0.55 millimeters, which is approximately half a millimeter. This fiber carries the laser's 100 watts. This fiber will be inserted into the fiber's working channel and we'll observe the white one. Shows up at the device's end, See? This fiber is displayed on the screen. All of our actions are performed with a clear view provided by the magnification from our micro camera. The laser I utilize has a dual pedal system that allows for adjustments in pulse wavelength to enhance coagulation. A longer pulse translates to slower energy delivery and subsequently more effective coagulation. If I want to open up the plane of nucleation, I use a shorter pulse length and it allows for better dissection. The pedals typically harness two types of energy, all running through this meager fiber here. With a thinner device, one challenge is the necessity for a precise surgical technique that entails coagulating the blood vessels to prevent bleeding. It enables less water-intensive surgery. The thicker instrument permits greater serum flow than the smaller one. So, lacking mastery in laser coagulation or alternative energy use often results in an inability to clearly see the plan. And with the precise technique and the use of this laser, which is a state-of-the-art laser, it has a better coagulation capacity, which is from Quanta System. We have a pulse modulation that allows this primary hemostasis. So before bleeding, we already coagulate. This patient is 1.55 m tall. Could you envisage inserting a 26 front device through a patient who is nearly 1.5 meters tall? When we operate on a 2-meter patient, the diameter of the urethra is larger than that of a small patient. As long as the patient hasn't suffered previous trauma, a scar, or undergone other procedures, a small device allows us to navigate any urethra. This surgery is highly safe. Let me demonstrate how the device gets inserted into the urethra. So we understand that there's a gap between the urethral wall and the endoscope, thus our actions are completely non-invasive. Small fibers are visible due to probing. The sphincter region is the canal's narrowest section. Typically, the device doesn't fit well through this area, but the thin device fits easily. Here you can see the prostate region and the growth of its two side lobes. Where's the urine pathway? It's non-existent. The fiber's end is 0.5 millimeter. The pathway is shorter than the fiber's end. You must continue pushing sideways until the bladder is reached. In this case, there was also the median lobe expansion, which occurs when the prostate grows into the bladder, forming something akin to a cork. Besides the lateral lobes, there's also a cork-like structure. We observe a highly trabeculated bladder, featuring a diverticulum. Due to immense internal bladder pressure, the mucosa has herniated amidst muscle fibers. Indicates a blocked bladder. And these beams here are collagen beams. It's a bladder that has been in this situation for at least 5 to 10 years. As the obstruction prolongs, bladder elasticity and contraction strength decrease, potentially resulting in acute urinary retention where the patient requires a tube placement, as occurred in this instance. So we're going to compare this image of the obstructed prostate with the final image after enucleation to see the difference. Endoscopically, we know that the sphincter is the narrowest part of the urethra, and here we can see the boundary between the lateral lobe and the sphincter region. Notice the mark from his probe? And this central part is the verumontanum, where the ejaculatory ducts are located. Here's where we extract the sperm from. So, what is our course of action? We identify that the only thing between the verumontanum and the lateral lobe is this mucosa, and it's already within the prostatic capsule. This is akin to the peel of an orange and is the portion that will remain. I'll extract everything within the adenoma peel to guarantee the durability and prevent recurrence of the operation. We observe here how the laser both slices and coagulates at the same time. When we engage the laser pulse, it aids in infiltrating the anatomical plane and detaching the adenoma from the peripheral area. The dissection is typically entirely blood-free. That's why I employ the less serum passing, thin apparatus, integral to minimally invasive laser prostatic enucleation, known as the MiLEP. We've already disconnected one side of the veromontana. Now it's the other side that's left on the patient, or the right side on the monitor. We'll keep detaching, understanding the need for complete removal. Owing to this laser's specific features, various kinds of lasers are available in the market. Laser technology is used for hair removal and eye surgeries in ophthalmology. Our laser for prostate enucleation interacts with water, differing from others that leave dark, carbonized tissue. It has a pulse peak that makes this detachment, so you can see the plane of dissection between the adenoma and the capsule. Identifying the sphincter boundaries is necessary to completely remove the adenoma without endangering the sphincter. This milk easily detaches without carbonizing the tissue. Other energy sources carbonize as they cut. Tissue turns dark, brown. It can be difficult to distinguish the peripheral zone from the adenoma. What does this imply? There's a risk of rupturing the prostate's outer covering. If it ruptures, fluid may seep into the abdominal cavity. The patient may not be able to remove the tube on the first day. If the rupture is particularly big, an incision may be necessary to drain it. One attribute of the HoLEP enucleation procedure is the necessity for an expert surgeon who can discern the difference between the adenoma and the peripheral zone. Identifying this difference enables us to execute precise movements and leave it well in the orange peel, which guarantees durability, but without the risk of perforation. Here, the adenoma, similar to the pulp of an orange, can be seen clearly in the midst of the clean orange peel. The vessels aren't even visible because of simultaneous coagulation by the laser. We're now progressing to further loosen the proximal limit, the separating line between the adenoma and the sphincter. This careful practice is critical to achieve immediate incontinence seen after almost 2,000 surgeries. This mucosa here has to be treated with great care because it contains muscle fibers that help with immediate continence after surgery. In this area, the thicker instrument often results in friction which can induce temporary incontinence, a common occurrence with enlarged prostates when such device is utilized. MiLEP's notable contribution is the reduction of sphincter damage, ensuring a more tranquil recovery period post-surgery. If the sphincter isn't placed under stress, it remains intact and perfect, allowing the patient to achieve immediate continence from the first day following the removal of their tube. We proceed further up the dissection, maintaining the sphincter mucosa's integrity visible. This precaution is crucial for immediate continence achievement that we achieve after almost 2,000 operated cases. At this stage of the surgery, we have completed the early release of the sphincter. If you notice, this is the veromontane, the opening of the ejaculatory duct. The outline of the remaining prostate capsule, referred to as the peripheral zone or the orange peel, is here clearly visible. And the pulp of the orange is all detached from the region of the sphincter, the entire circumference on both sides. The thin device and laser have already been employed in this detachment. When the mucosa remains unharmed, we achieve immediate urinary control or continence. And this is much easier with frictionless with the slimmest tools used. Now, we'll finish the enucleation by removing the remaining pulp of the orange, pushing it into the bladder. Afterwards, we will utilize the morcellator to suction and reduce the material into smaller pieces. The full adenoma is now entirely separated from the prostate capsule. The sphincter and mucosa are unblemished, without trauma, without any friction. The outline of the peripheral zone, which we call the orange peel, is all loose and the adenoma is centrally located. It's only adhered to the bladder mucosa now. Recall the bladder? Therefore, we can use the laser to make an incision in this mucosa and finish the enucleation process. The bladder mucosa is one of the most vascularized regions of the prostate, and you can see that the laser allows first-pass coagulation. Thus, we can cut this mucosa and coagulate it at the same time. making sure the tube is taken out in under 24 hours. Historically, extended hospital stays are linked to prostate surgery due to bleeding from the prostate and bladder mucosa during the postoperative stage. Following TRP surgery, the patient is typically required to have a tube flushing the bladder to prevent clot formation for approximately 3 days, whilst 5 to 7 days are necessary after open surgery. With the Holmium laser, we managed to coagulate these vessels, and all the blood vessels that would be bleeding are coagulated. This enables us to take out the probe tomorrow morning, thus we keep the tube overnight for irrigation. And in the morning we can remove the tube. The patient drinks water, fills his bladder, urinates twice. And after the second mix he is free to go home. I typically check in with patients around noon to discharge them. Remove tube at 10 a.m. The bladder neck adenoma's release has been successfully completed here. It's all below. The adenoma, or the orange's pulp, is essentially devascularized. The peripheral zone resembles an orange peel. With a characteristic, we can see that by removing all the adenoma, there's no danger of it growing again. The surgery is final. Various other procedures can create a passage through the adenoma and remove some tissue, but some remains. After a few years, the adenoma symptoms often recur. Enucleation assures that the removal is complete and long-lasting. Performing the surgery with a Holmium laser in a minimally invasive manner is known as minimally invasive endoscopic enucleation, or MiLEP. This approach, characterized by the use of the thinnest devices and a laser, originated in Brazil. This technique was first practiced and perfected here. I published it in 2022, showing that the surgery was feasible using the thinnest devices, as long as it was carried out using the precise technique of simultaneous coagulation along with dissection. The first stage of the surgery, the enucleation, is finished. The sphincter is in excellent condition, the prostate cavity is spotless, and all that's left resembles an orange peel. The complete removal of the adenoma ensures its longevity. I pushed this material into the bladder, which had initially obstructed it until it was blocked, only attached at the end. And I'm going to show you the incision at the end, which will detach this adenoma, and allows it to float freely within the bladder cavity. When it begins to float, we'll extract the adenoma with the morcellator. Patients should consider their treatment options carefully when dealing with hyperplasia. The question arises as to whether the extracted material will undergo microscopic analysis to determine possible cancer presence. Reason? Some techniques, such as resin, which is steam of water, or urolophus, which are clips, or even vaporization of the prostate with a green laser, which is another type of laser, you don't have material for analysis. And around 5% of patients who are operated on with hyperplasia may have a cancerous focus there. This procedure only removes the adenoma and doesn't treat or cure cancer. Diagnosis necessitates subsequent treatment. If the material isn't analyzed, diagnosis can't be made, and the cancer might proceed in advance. With the MiLEP, the entire adenoma is removed. 100% of the material is analyzed by the pathologist under the microscope. And I've made several diagnoses of aggressive cancers that have allowed the patient, at this early and asymptomatic stage, to undergo curative treatment and be cured of the cancer thanks to the diagnosis that occurred in the treatment of the hyperplasia. Once the enucleation is finalized and bleeding controlled, we need to replace the optics and install the morcescope. I collaborated with a German manufacturer from Tuttingham known as RZ Medicine Technique to design this optic. Dr. Felipe Figueiredo is in a position to provide me with the required arguments given my lack of professional medical knowledge. We merely manufacture medical equipment. We try to realize your ideas and we try to realize them in the best possible way. What's its function? 8 mm working channel that allows the morcellator to pass through. which is this thin little tube that passes through here. It comes out there at the tip, and it has a rotating blade that will aspirate the. After grinding up the bladder's floating adenoma, the material is expelled through a small tube for analysis. We've now switched to using a Figueiredo morcescope, which contains the morcellator's blade. By stepping on the pedal, it creates suction and oscillation which draws in and grinds up the adenoma. This ground material is then expelled through a small sieve. As well as suction, it also pulverizes the substance, allowing us to effectively remove the adenoma. And we send it to the laboratory to do the anatomical pathology examination. It's an extremely efficient piece of equipment. It can remove around 10 grams per minute. This design enables us to morcellate any type of prostate efficiently. We've already morcellated one of the lobes in 1 or 2 minutes and are now morcellating the second one. The morcellator, which operates under supervision as part of a safe procedure, functions like a high-intensity vacuum cleaner, complete with a suction pump. The process involves suction of a small adenoma piece into the tube, which is then severed by the fluctuating blade. But it does this 1,700 times a minute. The development of this morcellator has allowed us to treat prostates of any size using this technology. Last year, we performed 2 surgeries on prostates exceeding 300 grams, each lasting roughly 2.5 hours. Even though it can remove around 10 grams per minute, morcellating a 300-gram prostate takes over 30 minutes. After completing the morcellation, there's no adenoma left in the bladder. All the material has been successfully removed. We can now conclude the surgical procedure and insert the probe. One of the characteristics of the technology is that there can be an equipment failure. During surgery which involves sensitive equipment like a laser, an endoscope, or a morcellator, there's always a risk that one of these devices might fail. In such cases, with the patient anesthetized and in the midst of the procedure, it could leave us unsure of how to proceed. This is akin to being caught with our hands tied. One worry I had was recreating all the necessary equipment for the surgery. Today, we possess 2 high-powered HOMO lasers, 2 exceptionally effective piranha morcellators, one of which is from Richard Wolf, and 5 sets of endoscopes. Thus, each set here is comprehensive. It's equipped for a full surgical procedure, complete with the morcescope, the slender apparatus, and beyond the one already utilized, for others are available. So I can do 4 surgeries a day and always have a spare box. Why? If a component fails during surgery, I simply replace it with one from the 5th box. We always ensure to have a backup system in place during surgeries for enhanced safety measures, providing security for both the patient and me, the surgeon. So then,